of this virus stuff, and then I'll absolutely conclude all the little odds and ends by Monday. But I do want to get this done. So now we are busy in recording. I know it's the same stupid illustration, but it's the only one I got. Okay, a couple of things. I mean, as I looked at the exam, you can't hear. Everybody quiet. Everybody quiet. So I understand. I mean, there's not a lot to say. I mean, I'm not really going into detail. The exam is more, as I sent it to the print people, it's more about the categories and things. It's less about what they do. Okay, so I mean, I'm giving you some context as to what they do. That's what I'm doing now, but it's more about the categories. The questions are not about rabies virus. People foam at the mouth, and it's fatal, and it affects nerve cells in the brain, which it does. But when we get to that, we'll talk about that. That's when we get to the categorization and analyze the diseases and how to treat them. I'm trying to give you context. I mean, but by definition, this is Ebola is what's called a hemorrhagic fever. A lot of viruses, and we'll get to this and how bacteria and viruses do damage. This targets blood vessel linings. They leak. It's very inflammatory. There's a high fever. There's a lot of viruses that do hemorrhagic fever. Ebola happens to be particularly nasty. We're not sure exactly how it spreads. Whenever I have something that, I used to teach it fecal to oral, but now we know there's more ways. There are just more ways. It's just very, very difficult to deal with. So that's, I'm trying to keep it fairly straight. Here, these are the categories. Paramyxo. Para means alongside. Myxo means mucus. Myxo, which is influenza. Both of these, again, there is a little inconsistency in their shape. Technically, they're considered cleiform, but I won't ask you about it. I'm more interested in the categories. Paramyxo has a lot of things that affect us, and effectively they're all respiratory, but it's interesting, they don't always go in the respiratory system. Probably the most contagious respiratorily spread disease ever, measles. Okay. I mean, with these measles outbreaks, 99%, 98% of people who are exposed to measles who have not been immunized, and measles is still around, this is already proven, they're going to get the measles. Period. End of sentence. Just is. It's that kind of. That's why MMR was there. Measles is when we go, and we'll do it in skin diseases, a comparatively mild disease for us with rare complications. Because we're in a country where we have very good health care, quick diagnoses, and mostly kids get it, and moms and dads knew what to do. Rest in bed, plenty of fluids, blah, 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 something for the itching, and you're generally good to go. They don't have to go back out to work in the fields. It's not an area where the healthcare is very, very limited, and they couldn't even find out what it was. There's an abundance of cases, and the abundance of the overall health of the population makes it very, very difficult. We'll get to measles about that, but for our purposes now, keep getting messages. Oh, I got it. It's no problem. For our purposes now, we're just interested in categorically. They're enveloped virus, classically referred to as pleiform. The big players, and I'm sure there are others, measles, mumps, something called parainfluenza, which is probably a milder cold presentation, and RSV, which is respiratory syncytial, SYNCTIAL virus. You should all know what a syncytium is by this time, because you had the heart anatomy, right? So a syncytium is all the cells are kind of fused together. In the lung, they're not. But what happens is what this virus does is it causes the lung cells to fuse together, and it restrains the ability of oxygen and carbon dioxide exchange. It's also known, and this is very significant, respiratory disease of the newborn, except it's not restricted to them. Preemies and newborns, particularly preemies are most commonly affected. This is sometimes will be an extraordinary problem and a life-threatening problem in a nursery, a NICU, neonatal intensive care, where you're dealing with preemies and things like that. Because I do not know where did you do the respiratory physiology unit yet in lecture? Starting it now, okay. When you get to it, the idea of roughly about age 24, around 26 weeks of gestation, you start to produce something called surfactant from type 2 cells. And surfactant's a wetting agent because lung cells, when they expand and contract, if they adhere to each other, they can't expand well. And that's the big problem. When a lung collapses, you have to reinflate it because once those cells start to stick to each other, it makes it very hard to reinflate. That's why there's such a hurry to inflate a collapsed lung. Surfactant is a moistening agent that allows it to expand and contract. They're always somewhat expanded. That's the nature of the lung. Babies don't make that until about 26 weeks gestation before they're born. Preemies born before that, okay, had a very difficult time surviving. We now make surfactant in the laboratory, and it's improved preemie survival rates dramatically, probably into the 23rd and 24th week of gestation. That's what I mean. Holding your hand, little palm of your hand, babies to be, newborns to be, and they're super tiny, but that's the magic of that kind of a thing. It's there. RSV now has there's like a big three: COVID, influenza, and RSV. RSV is mutated a fair amount. We see it, you can see it in everybody, but the elderly are particularly, as well as the newborns, obviously, the very young and the very old. So it's a virus that now has become this identifiable virus, along with influenza and COVID, whatever the current COVID variation is, that creating a lot of problems respiratorily today. So we're going to get to all of those. Okay, and when we get into respiratory diseases, has got a lot. It's a big chapter. We spend a lot of time on that. Kind of starts our last unit when we get into the diseases, the last quarter of this term. Again, measles is very common. RSV, mumps is the only one that's different. They're all spread respiratorily, but it does not affect, per se, the respiratory system. These do. Measles' basic impact, even though it can cause pneumonia, is really classified as a skin disease because its major way we see it is somebody covered in red spots. Everybody got the measles when I was a kid. It was routine. And it's very, very distinctive. And maybe depending on where many of you may work or where you may live, you may run into a case or two of this. But it's hard to miss, believe me. So, but that affects the skin, where mumps, the other M of the famous MMR, glands, particularly salivary glands, but other glands are not excluded. So typically you'll see, and again, all of these are much worse in adults than they are in children, maybe with the exception of the RSV. And you see these little kids with these big chubby cheeks. They're not chubby, it's the glands, particularly the parotid gland here, that swells a lot. In adults, it hits reproductive glands, particularly bad in men with the testicles, but can also cause infertility in women. So the problem is what we call the usual childhood diseases. Children are because they typically have a high fever. Kids survive high fevers a lot more easily. 104 fever is not putting a kid in children's hospital. Is not. But that's the only thing. Depends on what other stuff's going on. You and I would be really ill. We're probably going to the hospital for that. It's a whole lot different. They can survive higher levels of fever without really experiencing the problems that adults have with regard to that. So that's my little nugget on paramyxo. That's there. So it's worth remembering the ones that are in that category. Parainfluenza, orthomyxo, whatever reason means straight mucus. So obviously it's respiratory. This is influenza. It's actually technically the one we worry about is influenza A. There's also a B and a C. They're mild. They're more like complicated. Influenza is unique, and I touched on it a little bit before. It's got 7 to 8 single strands of RNA. And this is just like COVID. you can have a variety of simple mutations. The one that we see the most by far, and why flu shots are not terribly effective, and why even if you had a flu shot, you can still get the flu, is because they're constantly mutating. The most constant mutation is this thing we call antigenic drift. And it's like little pieces, every time they replicate, RNA starts swapping places. And what it does, it creates irregularities on the protein spike. So I draw in here and label part of my handwriting, we'll have better illustrations. H and N are the spikes. This is really important. We get to a whole unit on influenza and respiratory diseases. This is the magic. They cause subtle alterations. So the way our body makes antibodies is we make them to those spikes. So if the vaccine makes an antibody to a spike that looks like this, and that spike mutates and all of a sudden it looks like that, it doesn't work. And it's doing it all the time. And we categorize influenza by those spikes because we even know what species typically have certain spikes. We hear about this in more detail. Again, this is not on this test, this is the context. These are called, the H's are called hemagglutinin. That's how they enter into your cells. The N's are called neuraminidase. That's how they exit the cell. So you see about what influenza strain. Back in 2009, there was an influenza A that had somehow acquired, and this is what happens with antigenic shift. Antigenic shift. Got a chunk. Shift means it gets it from another animal species different than what it has there. Let's say that's typically human, all of a sudden piece of, in this case, it was swine virus. Pig virus created a kind of what we call swine flu. Again, we do this more in earnest. This is not in this example. It doesn't mean close your ears. You shouldn't. It was H1N1. You may have heard these terms before. Because we have multiple different ones of these. We have H1N1, we have H5N1, H5N3. I think that the one we're experiencing this season was an H5N3 that caused a lot of problems. It doesn't necessarily mean it was one of these novel viruses. It was just a mutation that was particularly hard to deal with. We are going to get into that in some detail because it shouldn't surprise you that when we make targets and we start looking at different things to try to fight viruses, why do we understand? Why am I giving you all this stuff? Because if somebody takes you whatever kind of medication that they give you, an antiviral, the name's not typical, it's not the antivirals that somebody would have for influenza, Tamiflu. Okay, it's a neuraminidase inhibitor. So by knowing how it works and knowing how it attaches or leaves, we construct an antiviral agent to address that, to limit its ability to leave. It can't leave the cell, can't hurt you. Won't stop it from going in, but if you stop it from getting out, to win. The trouble is, it only works if you use it early. We'll get to that with antivirals and antibiotics, and antiprotozoans, and all that stuff. Those are the big ones that are left here. We don't do, as you might remember me saying, arena. Bunya, I will look, and please ask me on Monday. I do not think it is on the exam. We do it with respiratory disease. Hantavirus is important because we do see it. And again, depending on where you live, it may become impactful. Wherever you live, there's a whole subset of problems. Okay, here it's, to me, I think the biggest subset of problems we have are horrible winters. Okay, but having lived in the northeastern United States for nearly 75 years, yeah, it gets harder when you get older, unless you like to ski. But the reality is, I don't think any area where you live is what we call a panacea. There's nothing perfect. So, I mean, the climate's wonderful in Florida unless you start running for hurricanes. It's wonderful in the desert Southwest, but you have to deal with the dust and all the airborne things in the dust that can really hurt you. I mean, there's a lot. And heaven, in California, all of a sudden things could be sliding, mudsliding fires down the pit. Nothing's perfect. So you have to. That's sort of my little spin on the way things go. I don't, because it has been reclassified. A reverse transcribing DNA virus would suggest to me that we used to classify hepatitis B, which is a significant problem and is a killer worldwide. The vast majority of us are immunized for hepatitis B. I will talk about that when we talk a little bit about hepatitis. I'm not going to ask you about it on this test. Because again, it's the reverse transcription process I don't think is well understood. It used to just be considered an enveloped DNA virus. So it's changed a little bit. My guess is that means, I'm saying the guess, from what I understand, is the DNA expresses itself as RNA. I don't know what it's reversing transcription about, but I will endeavor to find out. And then lastly, and certainly the one that we're going to have to give you some, basically for this test, all you need to know about human immunodeficiency virus / AIDS. They are not the same. That's the virus's name. This is the condition it causes. It's an RNA virus. It's enveloped, which means it's very easy to deal with on surfaces. All of these are. Comparatively, any disinfectant will work. Again, with the understanding that something, when we're dealing with something like Ebola, it's a much more complicated in the way that you have to address it. But typically, I mean, the fact that somebody is HIV positive that you're in class with, or that's in your orbit, or that you work with, it does not mean that you're at risk. Okay? HIV positive is just simply a titer. It means they've been exposed to the virus and they make antibodies to it. I told you, my first wife was exposed to hepatitis C. She makes antibodies to it. That's how they identify it. It's not in her bloodstream. It's still potentially there and can come back. Most likely it's hiding somewhere deep inside of her liver. And if her immune system begins to go south, which it has previously, then we can have problems. And that's exactly what kind of happens when somebody's HIV positive. By definition, it is not fatal. They have a disease that unfortunately attacks the single most important cell in their immune system. When you do immunology, you didn't do immunology yet, did you? Well, the helper T cell. Helper T cell is the linchpin to get your immune system working. That's what this targets specifically. We call it a retro or backwards virus. That's the category because it reverses transcription, meaning the RNA in there is rewritten into DNA and becomes part of the host cell. That's why we use it, effectively a similar mechanism, and modify this virus to do genetic gene therapy to reprogram our own cells, which is it. So basically, you're trying to reprogram, say, your white blood cells to fight so you don't have a particular leukemia or something. Just arguments. It's been examined for a lot of different conditions. And again, there's nothing definitive, so it's not something I can get familiar with as yet until it becomes the kind of thing that is used all the time. So here we have, there's two different types. Type 1 is the one that's by far and away the most prevalent. Even in equatorial, I mean, it's rampant in certain areas. Equatorial Africa, I'll go into how it is when we really get into discussion about this particular virus. I have a tremendous amount of information. Recall me saying, because I say it to everybody. I mean, I was treating HIV positive patients and AIDS patients before anybody had a name. So it's a very interesting way. I'm going to see if I can find a link to this particular, probably a YouTube that you can find now, about what you really think about how this formed. And it had to do with people trying to make polio vaccine in sub-Saharan Africa in what they call the lab. You and I would call it a shack in the dirt floor, sick monkeys. Because of that, why is measles the third most common killer in sub-Saharan Africa? Okay, malaria, AIDS, Even though 30–35% of the population is HIV positive, thankfully, we have a lot of good medications to treat people who are HIV positive. That's why it's not fatal. A long lifespan, very, very noteworthy people, probably most noteworthy. One of the great basketball players of all time, Magic Johnson, who identified that he was HIV positive back in '91. Count them, 5 championships in the NBA with the Lakers. And continues to be a very active participant in basketball management, involved with a lot of things. Very controversial. 35 years old. But obviously, a world-class athlete, best possible care that he could get, even in the early stages. But now, most everybody can get that. What does fatal mean? It means to shorten your lifespan. People who are untreated or undertreated, what happens is eventually it's called a slow virus. Over 2 to 10 years, that's part of what we're probably going to see on Monday. It's a slow virus, so much so that it takes 2 to 10 years to demonstrate itself. Sometimes there are cases that come very, very quickly in that 2-year range, and most of them are closer to 8 to 10 years before it's a gradual transition, and we can monitor it by doing blood tests. But at that time, they should have been receiving care. A lot of times, it's too late. It's such an interesting disease historically in the limited time it's been around. And I mean, it's a rather lengthy discussion to have. And I'd rather get through this material today than to go into my knowledge about it and my being able to. I interacted with people who are HIV positive for a couple of years on a very, sitting as like all of you guys close together before we knew anything about it. Close friends, close acquaintances. So, I mean, it's not so easily transmitted as people might think. I wrote down some names here that are not going to be on there, but the big player is RNA reverse transcriptase. So, viruses sometimes have enzymes in the package. This one has a couple. When we get to how it works, RNA reverse transcriptase rewrites the RNA as DNA. Protease means enzyme that chops proteins. It's a very, very long strand of proteins that have to be chopped. This is one of the ways we target. One of the ways we have, here's 3 RNA reverse transcriptase inhibitors, protease inhibitors. Integrase kind of prevents the DNA from incorporating the host cell. So those are, by understanding the enzymes and how they work, that's where antivirals come from. That's why this whole spiel about that is apropos. Okay? So, I mean, for right now, all you got to know is it's retrovirus. HIV positive is not fatal. AIDS is, which means your immune system collapsed. And what does it mean to be fatal? You're going to die sooner than later. You know, it's going to shorten your lifespan. Effectively, people go, "Oh my God, it's fatal." Well, if I'm going to die in 20 years from now, at my age, I'll deal with it. Give me another 20 with something. Think of how many more students I can torture. Don't look at me like that. At least you guys interact. I have a class that's sort of, so I can forgive you if you're sleeping some of the time. I have a class that's always sleeping. How do you, well, my wife is accomplished. When I'm talking, my wife is rapid to go to sleep. All right. So that there ends the spiel on all these viruses. So I want you to know the categories that are there. This, we already covered that. There's very little to know about bacteriophage viruses. I used to do a big unit on it. Bacteriophage, and I'll get to them in a second. And I used to go into all this stuff about lytic and temperate, and frankly, you don't have to know that stuff. A bacteriophage, by definition, doesn't affect us. It's a virus that only affects bacteria. Again, we had this on the first exam. All living things can get a virus. Archaea, which we really don't cover here in this class, bacteria and eukarya like ourselves. Bacteriophage, they indirectly affect us. we are exploring because they attack viruses and damage them or destroy them. We are looking at them as an alternative to antibiotics because they don't clobber our cells, they clobber bacteria. They're funny shapes. You saw some of them before. I'll show this picture to you. Take a look at that thing. It's weird. Okay? So when we see it in action, it's extraordinarily odd. And so without going into all of this, the thing that is most interesting, without going into all of these things and how they replicate for now, because I really don't think it's relevant since we're going to talk about how human viruses do this, ones that affect us, but not and other animals, but not these. It's slightly different. Effectively, when I hear noise in the background, it bothers me. If I can hear you, it's not good. Text each other. Please, I'm not angry. I had this discussion with one of my colleagues today. She and I both believe the same. We're here to teach you. It's okay. It's okay. I don't get upset. I give you a hard time, but I'm never angry. I'm angry for a nanosecond. My wife will look at me and go, "Why are you always in such a good mood?" Because I'm here. Not here, but I'm around. You wake up in the morning, it's a good morning. You get to a certain point in time. I'm always like that. Please, you don't know I don't care if you have something to say and go outside or text these. I don't care. Study for another test. Watch whatever video you want to watch. Not that you're doing it. Maybe you guys are doing it. Please. Make my life easy. Because I get distracted. Don't laughing back there. We don't want to know about the social situation.
Lucas is the one that just threw my business out there, aired me out.
It's okay. Lord help me. Lord help me. It looks like this. This is basically just something that it's basically a mechanism to inject it into the cell. This stays outside, and then it shoots the genetic material in. It gives you an idea, and then I'm going to get to how ours work, where the difference is. So I don't really care about it. I'm not going to ask you about it. I want you to understand it's not the same as it affects us. Okay? Because they spend a lot of inordinate amount of time with these things. Okay? This is what affects us. When it infects, they have a fancy name for a latent virus. They call it a temperate phage. Same thing. The cell gets infected by one of these bacteria. The bacteria gets infected by a bacteriophage virus, and effectively, it just stays with it and replicates along with the bacteria. Okay? Fancy name, we call it a lysogenic infection. And what happens is, and I'm getting there, is this. Lysogenic conversion. I wrote it on the board a little bit before. Okay, so it can't be infected by a different phage. Not that that's a big deal. This is the big deal. Toxins encoded by that process. Okay, only the ones that have, they call it prophage, by that phage virus. When it incorporates, they call it prophage, a fancy term. It's a little confusing for students. Botulism. Okay, it gave it this toxin. Diphtheria, we're going to talk about in respiratory diseases. Whenever you get a tetanus shot, you're getting immunized for diphtheria. It's a trivalent diphtheria, pertussis, whooping cough, and tetanus, all the same shot. That's how deadly that thing is. I have a great anecdote about that, and it wasn't from me. It was from my nursing student in my first class that I taught micro. And I'll explain to her because she was from Russia, and she was there when this outbreak occurred. And it scared, I think I had 55 people in lecture. This was one giant lecture for 3 hours, and we all sat there with our mouths wide open and widening as she explained in gory detail how bad that disease was. We don't see it. We've been immunized forever. One of the earliest immunizations we have. Okay? It's called lysogenic conversion again. The nasty kind of E. coli that can kill you. That O157H7, it gets the toxin that causes your kidneys to shut down from this. Salmonella, okay, certain ways that it makes food poisoning. Scarlet fever, when we get to strep throat and the complications thereof. Cholera, a horrible, horrible, life-threatening diarrheal disease that you see after natural disasters, you see after wars. We're going to see cholera after what's happening in the Middle East. We are. So all of that it's worthwhile me telling you about that. For your purposes for this exam, know that bacteriophage only infect bacteria. They indirectly impact us. But when you talk about infect, it means it enters the cell. I'm not Vicky, I'm always mad. Stop it. I'm joking. Nothing. I say it's just you gotta stop partying those late nights.
Right.
Just saying. And I'm not going to. I intentionally skipped genetics and metabolic scheme. I'm going to do a take-home thing with that to make sure everybody has some little extra incentive for a more positive grade. I'll probably record a presentation. I wasn't that ambitious this week so far. I had other stuff going on, but I'm considering doing it over the week. It would be nothing that would be due before break. So always be after. No, I mean not that you have to spend time. I'll make a day after break. Not like it's due the Monday after break. It's okay. Moving on. So I'll do. We'll talk. You have to know. You have to know a little bit going forward. For many of you, from a standpoint for licensure exams and just for the course material you're going to be doing, you have to know about things called conjugation, transduction, transformation, transposition. You have to know a lot about those things. Those are 4 mechanisms, and to understand the genetic basis. Every time I have put that on the exam, that is the part that if I have 15 questions, average students get 10 wrong. And I go over it and over it again. But there's a certain material that you have to know about, something called the Ames test you have to know about. You have to know about mutations, the difference between silent mutations, basically mutations that basically silent is one, missense and nonsense are the others. So there's certain things that you have to be aware of in order for me to give you everything in the course. It doesn't require that I in class test you about this. I'm trying to think of the right way to express it. Good. Okay. Messages everywhere. This is what they do when they study it, and we do this in the advanced labs here. Okay, and probably in genetics lab, they probably use bacteriophage since they're not problematic to us. And you see these areas. Imagine your culture plate with areas where it didn't grow. Are you doing antibiotic testing yet in lab yet? No. You just did the selective and differential plates. Okay, down the road, you're going to put little discs on there that are basically to see how antibiotics are tested. This is kind of, they don't look like this, but kind of. And you get there. This you do need to be familiar with going forward. Okay, these are the infection cycle. For a virus to affect you, it's got to attach. So if it's a virus that affects respiratory, like a cold virus, and this is wash your hands, washing your hands, washing your hands. Here's a cold virus, and it's on your hands, okay? It can't hurt you. It only hurts you if you inhale it. It's spread respiratorily. So if we wash our hands sufficiently, there's nothing to attach to on your hands. So if somebody sneezes in class and you end up and you get something on your hands and you go, you're not going to die from it like you were COVID. get there and wash your hands or use the hand sanitizer. For the most part, it's out of the problem's gone. It's got nothing to attach to. If someone's HIV positive, if it doesn't get into your bloodstream, if it's not transmitted sexually, that's why this stuff is so important. It's not a problem. Oh my God, I touched a patient who's HIV positive. Who cares? That's why you wash your hands. Okay, so inadvertently, it doesn't, in some way, shape, or form, you get it on an open cut, you give it to somebody else who might be at risk, it has some other portal of entry or opening they can get into. That's why this stuff is important. So it's got to have something to attach to before it can do anything. And with viruses, that's very specific. That's that whole, is it respiratory? Is it fecal to oral? Lining cells of the respiratory tract, areas of the skin it can attach to. Okay. Friction begins to inoculate it effectively into the skin. Sexually transmitted, it can be saliva, it can be reproductive fluids, anogenital fluids, etc., etc. You get the idea without having to be overly graphic. Just so you understand, so it's got to attach. Okay, a lot of times, when we look at HIV, and there's a couple of decent animations that I have, and I mean, again, this is more contextual. It actually involves what's called a co-receptor. It's very interesting. That's how it hijacks the mechanism our immune system works. And so I'm not going to go into any more than attachments for now. For instance, there's a good example. Dogs don't get the measles. Oh, thank goodness, my dog won't be scratching and itching from the measles. But rabies, multiple hosts. The name, here, the name, I'm having a crackdown. We give to a virus is range. Range doesn't mean it's all over the country. It's how many different kinds of hosts it can affect. So rabies has a vast variety of hosts. Measles is us. Period. So that's the range. This is the important part about the infection cycle. So what it has to do, it involves, once it attaches, it gets pulled into the cell. It doesn't matter how it gets pulled in. Sometimes the membranes just bind to one another, and sometimes it's endocytosis. Go back to last term, we talked about endocytosis. It gets swallowed up by the cell. The receptors will trigger one process or the other. It doesn't matter. So first it attaches, then it enters the cell. One of those two methods. It's not, the distinction is not a big deal. Okay, now once it's inside, this is the critical step. It's called uncoating. Remember, those bacteriophage viruses, they inject just the genetic material. The genetic material does the bad stuff. Okay, the genetic material has to be exposed. In order for that to happen in our cells, it has to uncoat. It's part of what I was telling you about. We look at how it enters. We look at how it gets, basically how it enters, how it attaches, how it enters. Finally, when we get to this stage and it uncoats, we have another target. This is one of the early treatments for influenza. It really didn't work very effectively. They're still around. Okay, we stop uncoating. That's something very interesting about viruses. Most of the way we attack viruses is here. Effectively, once a virus enters your cell, it starts to take over the host machinery. It stops being a cell doing its job. It's no longer a lining cell in your respiratory tract. It's no longer a lining cell in the genitourinary tract. It's no longer a lining cell in the gastrointestinal tract. It's a little factory to make more viruses. That's it. Stop being that. And basically, the virus replicates itself. It replicates more of its either RNA or DNA. It replicates more of its capsid proteins. It replicates more of those protein spikes. And voila, it goes about hurting. That's how it works. And so they go through this way, and it's from these different steps. So to go backwards, It has to attach first, and then it has to uncoat. I'm not so worried about how it penetrates, etc., etc. I mean, I don't want to go into the distinction between membrane fusion or endocytosis, but the key is to uncoat. Once it's in there, it takes over. The viral genetic, RNA or DNA, basically, and if it has any enzymes, like, and retroviruses aren't the only one, it begins to take over. It makes more proteins, it makes more enzymes, it makes more RNA and DNA, and it assembles them. It's like an assembly line. We always talk about everything living. We talked about our cells, mitosis or meiosis. Bacteria, we talked about, basically, it just replicates, just binary fission. It keeps duplicating itself, duplicating itself, duplicating. Ah! This is like an assembly line. You're making capsid proteins, you're making protein spikes, you're making RNA and DNA, and everybody in the back, it's like working on an assembly line in the old days where everything had robots and automation, and you basically put it together. When you make enough of them and the cell's ready to explode, it explodes. It's called the burst size. Sometimes that a cold would do something. Others we make and we make and make and continuously spit them out. Those are typically when you're going to see the ones that are enveloped viruses, like HIV, like influenza, like COVID. There's other stuff that they do to hurt you at the same time. Like COVID happens to target a receptor and causes it to make nasty things occur in your lung. This is the way it works. And then they call them replication strategies. You'll be happy to know I don't get into. You don't. I'll talk about them, but you don't have to get into. The one that is, I mean, when you start looking at this, positive sense strands and negative sense strands, most students go, I don't even. This is beyond me. I'm just going to go guess on the test. It's okay. Nothing wrong with that. That's why I don't. I'd rather have something that's useful to you than something that no one will ever ask you about. I defy any of you to come back and see me 10 years after you've been on the floor to see if is that a positive or a negative sense strand virus? Never going to happen. I mean, get on FanDuel and whatever those the betting apps are. It will never happen. You'll get ridiculously good odds. They're different. So they're all like that. And we'll get into all of these different things. The unique thing about the retrovirus, when we get to it, okay, it makes DNA, and I'll probably go back to this slide. And then from the DNA, it has to make RNA, and then different things happen. So the complexity of that step, the good news about it gives us a lot of targets to address the virus. The bad thing about it is you have to simultaneously hit 3 or 4 of those targets. When we talk about antivirals, we used to have a minimum of really using a triple cocktail. Now we use 4 agents in a cocktail to address it. And thankfully it is made fairly cheaply is the wrong term, inexpensively is a better term. With a lot of these, HIV is sort of the poster child. And maybe we'll end with this little bit of history. I think what's coming up is, and this is how it enveloped virus, just to complete my thought about them. They're made inside, and what happens, they're kind of spit out, and on their way out of the cell, they grab some of the membrane, and there the protein spikes are on. So the virus is busy in the cell implanting the membrane with protein spikes, and on its way out the door, once it's assembled, it picks up a piece of membrane through the envelope, which already has the spikes on it, from what the virus is doing inside the cell. So to get back to therapeutics, everybody grew up when AIDS started. Oh, this is retribution for gay people. It's a horrible lifestyle. Oh my God, terrible stuff. This is more than 40 years ago, nearly 50 years ago, we started to see this. And everybody, because when they identified it back in 81 with a study on gay men out in San Francisco, and people were so misinformed. If somebody had this, I mean, you wouldn't even go within walking distance of the house. Oh my God, it's terrible. And like someone like me was having lunch with these folks, my downstairs neighbor, Philadelphia, and all of his friends. So it's terribly misunderstood. So much so that people were closeted by it. Okay? Much less by coming out because you have a particular lifestyle that's alternative, coming out and telling somebody you're HIV positive, which it wasn't happening. So until famous people started to die because of this, and everybody who knew about that, it was particularly in the entertainment industry. Famously, an actor named Rock Hudson, who was an action star back in the day, maybe the most famous entertainer, the biggest, hardest ticket to get in Vegas, was a guy named Liberace, way before your time. Everybody wanted to see. He did a great show on HBO. Matt Damon did it, and Michael Douglas did a really good movie about his life called The Last Candelabra, something like that. And it was a very interesting entertainer. When they started to succumb and it was revealed what their lifestyle was, the Hollywood people said, listen, a lot of our friends have this. And they actively lobbied. They put a lot of money into politicians and got them to sign something called the Orphan Drug Act. It had nothing to do with orphans. It was back in 1988. It basically was an incentive for the pharmaceutical companies to make drugs, antivirals particularly, to fight diseases that didn't infect a lot of people. Because pharmaceutical companies, there was no market for it. We'll make a lot of amoxicillin. People buy that all the time. But making stuff to take care of this very limited population, no thank you. It gave them financial incentives, what they wanted, and encouragement, and fast tracking them rather than the usual 7, 10, 15 years to get it to market. It's time to become familiar with the business of medicine and the business of pharmacology. That's all part of it. So I'll leave you with that, and we'll pick up specifically in this chapter with a few thoughts. Thank you.
I was in real